Здравствуйте, уважаемые коллеги. Oh, no, this is an English section, yeah? Hello guys, hello my college. Today we will talk about principles of trauma management. It's a very important topic and may I tell you why? The importance of injury is a public health issue, including surveillance, prevention, economic impact, and functional outcomes. The importance of the injury mechanism in predicting actual injuries, the differing implications of blunt and penetration injury, the importance of triage and team-based approach, the importance to the triage process of injury mechanism, physiological status, evident injury, the differing risk exposures and injury patterns in children, young adults, and the elderly. The patients of associated injuries that are commonly observed. The commonly documented definitions in acute injury management. The importance of an integrated trauma treatment service in a hospital. The value of clinical practice guidelines for the assessment and management of acute injury. The importance of regional systems of trauma care that link injury prevention activities, pre-hospital care, acute care hospitals with differing roles, rehabilitation services, and the overall return to premorbid functioning. Uh, all this page, all this slide tell you that we need to create some principles of trauma management to decrease a problem what happened when we have some trauma. Trauma system planning. When examining deaths due to injury, there has been a fairly consistent finding worldwide that where systems of trauma care have not been specifically organized. 15–13% of the deaths can be deemed to have been potentially preventable. In addition, approximately two-thirds of deaths in the absence of serious head injury have been deemed to be potentially preventable. Much has been done to improve this situation with respect to education, standardized care, and recognition. But more progress is still needed. Considerable attention has been given internationally in recent years to the appropriate design of regional systems of trauma care that enable patients with potential serious injuries to access a process that minimizes the time from injury to definitive care. The aim is to get the right patient to the right hospital in the right time. The essential components of such a plan are outlined here. There we see what we need to do in pre-hospital stage. Yes, we need do a pre-hospital triage and pre-hospital treatment and transport decisions. Triage is the process of grouping injury victims according to risk of death or other adverse outcome. Pre-hospital care providers are trained to carry this out using a criteria-based system usually employed for simple groups of factors. First, physiology. The vital signs such as pulse over 120 per minute, systolic blood pressure less than 19 millimeters Hg, Glasgow Coma Scale, score less than 15. Point of care testing. For example, blood gases. The next one, anatomy. The immediately evident injuries such as fractured long bones, pelvic fractures, spinal cord injury, flail chest, positive FAST. FAST is a focused assessment using sonography for trauma. Mechanism of injury, for example, fall of more than two mechanisms, injury to two or more body regions, vehicle crash with ejection, penetrating injury, significant burns. Patient factors, extremes of age, use of anticoagulants, pregnancy. Pre-hospital treatment. On the basis of the triage process, certain predetermined decisions are made then that attempt to direct the transport of patients to the most appropriate hospital. Pre-hospital care providers are trained to recognize and treat life-threatening problems in the field, including airway interventions, chest decompressions, and administration of blood products and application of splints and pelvic binders. You need to understand that the most appropriate hospital is not necessarily the nearest hospital. The pre-hospital triage process should identify patients who need to bypass the nearest hospital for one that the resources and expertise to care for all types of serious injuries. Categorizations of hospitals. The role of a hospitals within a regional system of trauma care is designated by the appropriate health authority. A major trauma service, it's level 1 of hospitals, has the facilities and internal organization to support its role as the most appropriate primary destination for patients with potentially serious injuries. Some patients can be appropriately triaged to level 2 and 3 centers in the urban environment of the above criteria. In semi-rural, rural and remote environments, strategically located regional trauma service, for example level 2 or 4, are required. These smaller trauma services must have strong links with major trauma services. Even in remote environments, trauma care education trauma service planning, and strong links with the rest of the regional network need to be continuously promoted. Hospital trauma response and trauma teams. Initial assessment of trauma patients requires an organized trauma response that aims to minimize the time from injury to definitive care. Such trauma response or teams have a predetermined multidisciplinary membership, a triage device to trigger mobilization, predetermined roles for members, and standardized approaches to the performance of primary survey, resuscitation, secondary survey, and investigations. Most importantly, the presence of a senior surgeon has been shown to facilitate timely decision making, investigations, and both operative and non-operative management, resulting in better patient outcomes. There you see goals of trauma assessment and their resuscitation. General goals. The sequence of goals in the initial assessment of an individual trauma patient is as follows. Save life. This requires knowledge of the causes of death. Second, prevent mere disability. This requires knowledge of the causes of disability. Third, diagnose and appropriately manage all injuries. Fourth, avoid unnecessary investigations or interventions. Achieve by minimize the time from injury to definitive care. Do not allow obvious injuries to distract from diagnosing other less obvious injuries. Third, follow the principles of ABCDE. Always have a clear management plan. Is the 4 and 5. Assess response to intervention by re-evaluation of the patient. Disaster management. Certain natural and human disasters, as well as terror-related incidents, can result in multiple casualties that may overwhelm otherwise well-resourced hospital. The increasing incidence of these events requires pre-planned disaster responses, training of response personnel, and simulation exercises to ensure that the principles of acceptable injury management are applied. The principles of disaster management are designed to achieve the best outcomes for the greatest possible number of casualties using standardized approaches. Blunt and penetrating mechanism of injury. The patterns and severity of injury differ dramatically between blunt and penetrating injury. The severity of injuries relates to the amount of energy transferred in the injury process and the amount of the body across which the energy is transferred. Um, Serious injury from blunt trauma is typified by victims of traffic-related injury or by falls from a significant height. In this situation, large amounts of energy are often transferred across broad and multiple regions of the body without breaching the walls of the body cavities. Accordingly, certain injury patterns can only be broadly anticipated, and acute injuries are not uncommon. Penetrating injuries are divided into those that result from gunshot wounds and those from stabbings. A further small group are patients who suffer impalement. It's important to recognize that interpersonal interpersonal violence can combine mechanisms: gunshot wounds, stabbings, and uh, blunt injury from a first or a boot. Possible injuries from stab wounds can often be fairly confidently predicted as energy transmission, and tissue disruption is limited to the penetrating tract. However, gunshot wounds can pose additional difficulties because the missile path may not be predictable and energy transmission and tissue disruption can cause gross destruction of surroundings, soft tissues, through cavitation and other aspects of ballistics, and the physical features of the missile, such as velocity, size, mass, and impact surface, because of the uncertainties posed by these features and the potentially serious nature of possible injuries. A lower threshold usually exists for comprehensive investigations and surgical exploration in the presence of gunshot wounds than with stab wounds. Death from injury can be broadly divided into four groups that link the causes of death to the time from injury to death. First is death at the scene, second death within minutes, third within hours, fourth with over days. And now we will talk about examples. Death at the scene, it's a brainstem transection, high spinal cord transection, decapitation, mere thoracic vascular injury with free intrapleural bleeding, mere tracheobronchial disruption, liver avulsion, and cardiac rupture. Causes of death from injury within minutes. Hypoxia, airway obstruction, tension pneumothorax, open pneumothorax, massive flail chest. The second one, mere bleeding. There we include internal bleeding, for example, amputation, thoracic, hemathorax, abdominal, spleen, liver mesentery, Meyer vessels, and pelvic fracture. Pericardial tamponade, cardiac rupture. The reason of this is a cardiac rupture. And rapid tentorial herniation, rapid rise in intracranial pressure. With ours, this is hypoxia, includes severe pulmonary contusion, tracheobronchial rupture, diaphragm rupture. The next one, sepsis, perforated hollow viscous, e.g. thoracic, esophagus, abdominal viscera. Bleeding, external face, massive wounds, thoracic aortic rupture, lungs, chest wall, liver, spleen, retroperitoneum, pelvis fracture, long bone fracture. And the last one, coagulopathy and brain, where we see increasing of intracranial pressure, hematoma or swelling. Over days, brain, high ICP from brain swelling, no cerebral perfusion. Respiratory failure, pneumonia, severe pulmonary contusions, fat emboli, type 2 respiratory failure in elderly. Hypoxemia in settings of hypercapnia. The next one, renal failure, crush injury, acute on chronic contrast, nephropathy. Gastrointestinal failure, especially liver, get mucosal barrier. Sepsis, it includes pulmonary abdominal wound, ischemia, muscle groups, liver, gut, myocardial infarction, and pulmonary embolus. How we can to prevent death? Many patients in the first group are recognized as late septic complication or multiple organ failure. However, the foundations for these late complications are often laid in the first hour or two following injury. They relate to the extent and duration of physiological disturbance. It is therefore clear that they can also relate to the promptness and completeness of early assessment and resuscitation measures. Prevention of death can be linked broadly to the principles. And now we will talk about these principles. They relate to general and local measures. General measures optimize oxygenation, optimize perfusion acutely, meticulous continuous fluid management, thrombosis prophylaxis, adequate nutrition by appropriate route. And local measures, it's arrest of minimized bleeding, correct raise of ICP, control leaks, tracheobronchial, esophageal, abdominal, hollow viscera, pancreas, urinary. Decompress or revascularize ischemic tissue promptly, debride dead tissue aggressively, debride and clean contaminated wounds. Disability principally relates to cognition, locomotion, manipulation skills, and chronic pain. While definitive care of the actual injuries plays a major role in preventing these categories of disability, it must be recognized that ensuring adequate oxygen delivery to brain and to muscle groups also plays a major role, especially in the first hour or two after injury. As with death, prevention of disability is linked to specific measures. Prevention of disability. There we include general measures, optimize oxygenation, optimize perfusion, protect spine, correct raised ICP, and local measures. There are reduce dislocation as soon as possible, realign fractures as soon as possible, correct local ischemia early, diagnose and decompress compartment syndromes early, prevent secondary damage to nerves, debride ischemic tissue early, debride contaminated wounds early, find the minor injuries to ligaments, joints, and small bones. Initial assessment. Efficient initial assessment of a trauma patient derives from the broad principles outlined previously, a clear understanding of the patients of death and disability, and recognition of the following factors. Trauma patient assessment is different from that of the usual patient. The traditional approach of taking a full history, doing a full physical examination, determining a previously diagnosis and a list of differential diagnoses, and deriving a logical plan for investigation and treatment needs to be laid aside in order to first ensure a patient's survival and then to ensure the smallest possible risk of major complication. Minimize the time from injury to definitive care with special attention to recognition and management of hemorrhage. Any single measurement of physiology, for example, pulse, respiratory rate, Glasgow Coombs scale, and blood pressure is of limited value. Overall trends and specific tests are more informative, for example, blood gases or viscoelastic testing. Life-threatening injuries may be occult. Multiple life-threatening injuries may coexist in different body regions, and the injuries that appear most dramatic may not be those that pose the greatest risk. The concept of golden hour is important. A 1 or 2 hour period during which all opportunities need to be taken to discover injuries that may cause death within minutes, and then to discover injuries that may cause death within hours. Repeat. Pre-planned protocols or evidence-based guidelines help to prevent errors in care. And now we have one table. This figure is outlines a well-accepted approach to the first 24 hours of injury management. The term initial assessment applies particularly to the elements to primary survey, resuscitation, secondary survey, monitoring, reassessment, and specific investigations. The term definitive care relates to specific treatment aimed at establishing the optimal conditions for the healing of specific injuries. The strategy of primary survey and resuscitation is outlined in figure 48.2. The ABCD sequence prioritizes the importance of specific injuries and assist clinical performance. Primary survey is the process used to assist the recognition of acutely life-threatening injuries and should process concurrently with resuscitation. As the primary survey assessment scheme is followed, intervention should be taken immediately to correct the problems that are identified. Measures to protect the cervical spine when attending to the adequacy of the airway. External bleeding must be controlled. Direct pressure is usually effective. In a hospital with a major trauma service and an effective trauma team response, there will be enough team members to perform some parts of the primary survey concurrently, together with the necessary resuscitative interventions. However, when resources are limited, the framework illustrated in this figure assumes even greater importance. This table provides further detail regarding primary survey and resuscitation. Effective primary survey are a limited number of life-threatening entities. Rapid and simple systems of physiological assessment and awareness of a menu of interventions that can be applied to correct the identified problem. Some aspects of care during the primary survey need special emphasis. The next one. Imagine. Just okay. The only appropriate imaging at the time of the primary survey should be directed towards proving or excluding a source for hemorrhage leading to hemodynamic instability. These include a chest X-ray, pelvic X-ray, and fast examination about sonography. Lateral C-spine X-rays are not required in initial patient assessment given the primacy of hemorrhage identifications and control. In major trauma patients, spinal injuries and presumed until excluded by the further assessments and CT scanning, it is important to minimize movements of the cervical and thoracolumbar spine until after the completion of the primary surgery or later to if other injuries or unstable physiology take priority. Primary surgery and resuscitation. There we will talk about problem and how we can assess the problem. First, we talk about airway, and there we have some problems like direct trauma, disruption, edema, obstruction, foreign bodies, blood and vomitus, soft tissue edema, deteriorating, and consciousness. How we assess it? We see cyanosis, tachypnoea, voice, stridor, confusion, respiratory distress, air movement. And we can intervene this like glove finger light suction, laryngoscope, forceps, oxygen, chill lift, jaw thrust, oropharyngeal airway, nasopharyngeal airway, orotracheal tube, supraglottic airway, video-assisted laryngobronchoscopy, surgical airway, cricotiroidotomy, urgent tracheostomy. The next one is spine. The problem is unstable fracture. Assume if unconscious, head injury, face injury. Intervene, protect C-spine, limit mobility, color, send backs. Breathing. Problem is tension pneumothorax, massive pneumothorax, open pneumothorax, massive flail, reduction in level of consciousness, poor effort, high spinal cord injury. How we assess it? Cyanosis, tachypnoea, confusion, respiratory distress, shallow respiration, poor expansion, asymmetric expansion, hyperinflation, hyperassonance, breath sounds, tracheal shift, diaphragmatic breathing. Intervene. Oxygen, ventilation, needle of finger thoracostomy, tube thoracostomy, tracheal intubation, cover open wound, three-sided dressing. Circulation. There we talk about bleeding, assess pale, clammy, cool, peripheral cyanosis, confusion, tachycardia, low pulse volume, slow capillary refill, neck veins, heart sounds. How we can to intervene it? It's like hemorrhage control, direct pressure or surgery, give oxygen, intravenous access, large bore 2, warm crystalloid blood products, packed red blood cells, fresh frozen plasma or plasma concentrated, platelets, cryo red precipitate, blood warming, gastric tube, surgery, urinary catheter. Shock. A primary goal in minimizing death and disability is to ensure adequate oxygen supply to peripheral tissues. The most urgent threat to achieving this is interruption of oxygen supply. The next most urgent threat is interference with alveolar oxygen exchange. The third most important threat is failure of peripheral delivery of oxygen. Clinical observation. There we talk about non-normal complications of shock, and the clinical observation or signs of shock looks like problem with microcirculation of the skin. We see pale skin. Problem with brain. We see any problem like patients are very emotionally, patients are very activity or non-activity. And the last one is kidney. When we when we stay a urinary catheter and we see a urina and we have to assessment it. The acid-base status of the patient, as manifested in the results of arterial blood gases, gives an indication of the magnitude of the microcirculatory failure and is an invaluable tool for assessing shock and the response to resuscitation in a critically injured patient. Cardiac arrest. From time to time, injured patients present in actual or impending cardiac arrest. It's generally agreed that attempted resuscitation of patients who have no vital signs at the scene of injury will not restore life except in some circumstance where hypothermia is extreme. When patients who have arrived with recordable vital signs deteriorate rapidly so that cardiac arrest is imminent, there is no time even to carry out a rapid systematic primary survey. Management is simplified by rapidly instituting the maximum response to potential problems with airway and breathing and circulation. This involves endotracheal intubation and controlled ventilation with 100% oxygen, insertion of bilateral intercostal catheters, and insertion of at least 2 large bore intravenous cannulas to facilitate infusions of formed blood. External bleeding must be rapidly controlled by direct pressure. Also, victims of blunt trauma who arrive at hospital without vital signs are unlikely to be salvaged by the most aggressive resuscitation. Patients with subdiaphragmatic hemorrhage and circulatory collapse may be salvageable with limitation of systemic circulation. Resuscitative endovascular balloon occlusion of the aorta, thoracic aortic cross clamping via left arterial lateral thoracotomy. Volume resuscitation and immediate definitive surgical intervention. In the setting of penetrating injury leading to cardiac arrest, there is greater opportunity for patient salvage. These patients require immediate resuscitative thoracotomy with or without pericardotomy and aortic cross clamping in the emergency department to restore central perfusion, heart and brain. Patients will then need definitive surgical management in the operation room. Insertion of a gastric tube can be a life-saving maneuver if it is used to decompress a full stomach and avoid aspiration of gastric contents. A gastric tube should be inserted usually towards the end of the primary survey in all trauma patients with mere abdominal injury, mere chest injury, spinal injury, brain injury, mere burns and shock. Gastric distension is particularly common in injured children. In injured children. In most situations, the gastric tube can be placed through the nasal route. However, in patients with a high likelihood of basal skull or cribriform plate fracture, it should only be placed by the oral route. There is no great urgency to insert a urinary catheter, but it is helpful if used in patients with potentially serious injury and is inserted at the end of the primary survey. The observation of gross hematuria or documentation of microscopic hematuria may have important diagnostic implications. However, once the bladder is empty, monitoring of the early urine output is an important part of assessing the response to intravenous fluid resuscitation. In nearly all patients, a urinary catheter can be placed by an experienced operator. If it cannot be gently advanced, it is advisable to seek a urologist support or suprapubic catheter placement needs to be considered. The emphasis in secondary survey is on identifying anatomical injuries and providing clinical information that will determine the need for plain X-rays and other special investigation. It is a careful and methodical physical examination from head to toe. It requires close inspection, careful palpation, and appropriate auscultation. Common omissions resulting in delayed identification of injury include examination of the entire scalp, careful inspection of the back area. We always need an airlock roll, inspection of the perineum, and inspection of the axial zones. This table outlines a useful sequence for the execution of the secondary survey. It also indicates the common general abnormalities that may be observed and highlights some simple procedures that assist with pain relief, reduce the risk of infection, and lead into the definitive care phase of early trauma management. Monitoring. Injuries may be multiple and acute, and therefore repeated examination and close monitoring are essential, particularly in the first 24 hours following injury. Injuries may also progress to become life or limb threatening, and recognition of these possible patterns of progression are essential. The monitoring strategy varies with the known injuries, comorbidity and age factors, other anticipated injuries, and the potential consequences or complications of the known injuries of their management. Oxygenation. Monitoring of oxygenation, airway and breathing may include skin color, level of contusions, respiratory rate, and the respiratory system, chest X-rays, pulse oximetry, capnography, arterial blood gases, and ventilation pressure. Circulation monitoring may include pulse rate, blood pressure, skin color and temperature, level of consciousness, urinary output, assessment of volume status, and cardiac function. Serial hemoglobin, uh, arterial blood gases, drain outputs, for example chest tube, as well as related physical examination of the abdomen and wound dressings. Central nervous system monitoring relies heavily on physical examination and serial CT scans. When CT scans reveal significant injury, an intracranial pressure monitoring device may be required. Serial documentation of the GCS score is imperative in patients who are not sedated and paralyzed. Early detection and treatment of sepsis are important. Temperature regulation and avoidance of extremes are important in limiting adverse consequences such as coagulopathy with hypothermia or secondary brain injury with hyperthermia. Definitive care is the phase of early trauma management when particular injuries receive their specific treatment. Much of this takes place in the operation theater, and in situations of multiple major injuries, a number of surgical subspecialty teams may be involved. In this in this table, uh, emphasis is needed for resuscitation to be continued and for monitoring and reassessment of a patient's response to resuscitation to be conducted. Throughout this and all other phases of care, any deterioration in a patient's physiological status should lead to urgent reassessment of the primary survey priorities and immediate intervention when actually life-threatening events are identified. Definitive care continues through any necessary stay in the intensive care unit and through early convalescence on the hospital ward. As our systems of trauma care improve, the interface between acute care and rehabilitation should become progressively more invisible. The tertiary survey is a repeat clinical examination along the lines of the primary and secondary surveys. It is performed with the aim of identifying injuries that have been missed during initial assessment. It's best performed after the early phase of definitive care and is most likely to be done if viewed as the first routine clinical task on the morning after admission of the patient to hospital. In addition to clinical examination, all X-rays and CT scans should be reviewed, along with final consultant radiologist reports and new X-rays or other tests organized as indicated from the physical examination. Injuries that may not have been identified during primary survey often have great functional importance and impact the return of the patient to normal occupational, family, and social functions. They usually pose little threat to life but often would lead to locomotor or manipulative disability if indicted and untreated. Examples include cervical spine injury without neurological deficit, fractures of small bones in the hands, and feet ligamentous injuries to the knee or ankle, dislocated acromioclavicular joint and peripheral nerve injuries. Review of previous X-rays will sometimes result in a new diagnosis of pneumothorax, widowed mediastinum, pelvic fracture, or rib fractures that require specific management. Visceral injury, solid organ or hollow viscous, may not be appreciated on clinical examination or even on CT imaging, and must be considered especially in patients who tend to develop several things. In addition, mild traumatic brain injury may have initial signs of other than amnesia. These patients should be formally assessed using a test such as the post-traumatic amnesia test, which is administered in the hours 2 days following injury. Outcomes. Prevention of death and disability. In accordance with these strategies, deaths that are avoidable can usually be prevented. Diagnosis of any problems must be early. Surgery must be prompt. Applications and extension of the principles outlined for prevention of death will also succeed in minimizing disability. It is critical that any major or maturing trauma system has a functional trauma registry that incorporates information on injuries sustained and specific criteria of initial assessment and management that can also be used as markers indication adequate or inadequate care. Additionally, it is important that details of complications and information on outcomes and lengths of stay are included. It's only with this information that objective comparisons can be made and assessments of adequacy of care undertaken. Performance improvement refers specifically to a process whereby care is objectively assessed and strategies are implemented to either better the process of care or result in better patient outcomes. This approach requires objective collection of information, a robust system of review or audit strategies to ameliorate demonstrated deficiencies and repeated collections of data to assess efficiency of changes. It is only with repeated cycles of assessment and change that better overall results and outcomes can be achieved. That's all. Thank you for your attention and follow me. Thank you very much. Bye bye.